What are mind-body practices? This is printed in the IASP newsletter. Mind-body practices are activities defined by their focus on interactions between the brain, mind, body, and behavior, and their aim to improve well-being and quality of life with possible health benefits. Some of these practices involve body movements. Example techniques such as Pilates, Tai Chi, yoga, dance therapy, controlled breathing. Examples hypnosis, meditation, yoga, and or therapeutic touch. A commonality of these practices is to work with the ability of the brain and mind to modulate physical functioning or bodily perceptions and promote better health. Some of these practices involve the experience of a non-ordinary state of consciousness. Example, a trance state. Whether this state is an explicit tool of the intervention, example, hypnosis, meditation, or more of a byproduct the therapist might use or not. Example, art therapy, guided imagery, and yoga. These practices are typically administered or taught by a trained practitioner with encouragements to practice autonomously, as they can be used to improve the repertoire of strategies for symptom management and self-care. Importantly, while the potential benefits of mind-body practices are generally acknowledged to improve global well-being, recommendations for their implementation in clinical practice must be based on demonstrated efficacy and ideally on empirically supported theories of mind-body interactions. Some of these practices focus more on the mind, example on cognitions and emotions, to improve an individual's physical and psychological function, such as cognitive behavioral therapy, CBT, or more on the body continuum, such as massage, and are covered in other fact sheets. Mechanisms of action of mind-body practices. There are two main approaches to establish mechanisms of mind-body practices for pain management. One focuses on the study of processes engaged by the mind-body intervention itself and aims to provide a broader conceptual framework to explain how the intervention may produce a variety of effects, including improvements in pain. The second is centered on the targeted pain outcomes by providing complementary measurements relevant to the underlying pain-related processes, the nociceptive physiological action, inflammation, and assess criterion validity beyond self-reports of pain relief. Scientific understanding of mechanisms underlying the effects of mind-body practices is in its infancy, but notable advances have been made on several fronts. Given the diversity of mind-body practices, no single underlying scientific theory is likely to account for all possible effects on health. Many approaches involve focused attention on sensations or body movements, including those of respiration, the engagement of the brain executive functions underlying the meta-awareness of mental contents, and the cultivation of a non-judgmental stance, characteristic of mindfulness-based approaches or other contemplative practices. Accumulating evidence suggests that these practices may produce improvements in the autonomic and hormonal stress responses, in immune, inflammatory, and epigenetic activity, and in telomerase regulation, with changes observed in brain morphology and function occurring with intensive or long-term practice. The available evidence provides a plausible theoretical framework that justifies testing their efficacy in pain management. One approach has been investigated more thoroughly, but over several decades, is hypnosis. Specific techniques have been adapted to pain management and supported by experimental studies exploring the underlying mechanisms. A meta-analysis has provided strong evidence that hypnosis reduces acute pain perception and physiological responses evoked by nociceptive stimuli. Functional imaging studies have shown that hypnosis engages brain regions underlying executive control systems. Clinical evidence in favor of mind-body practices in chronic pain. There's a large pragmatic use of mind-body practices in an effort to self-manage pain. Despite limited evidence of the benefits, this is not that recent. However, an important variability in the evidence at hand may be underlined depending on the specific therapy under scrutiny and the treated pain condition. Here we'll present some of the validated techniques as an illustration of the research at hand and without aiming at being exhaustive. Hypnosis, meditation, and yoga have the strongest scientific support among mind-body practices for chronic pain. Research has shown that when compared with standard care, hypnosis can deliver meaningful pain relief both in adult and pediatric patients. There's some evidence of medium-sized effects in both pain severity and interference in patients with cancer, and on pain intensity and function in adults with knee osteoarthritis. It's interesting to note that there is some preliminary evidence that a group format could be an effective delivery system for teaching hypnosis for chronic pain management. There's also strong evidence for short-term effectiveness and moderate evidence for long-term effectiveness of yoga for chronic low back pain, as well as impact on frequency and intensity of tension type. There is some low-quality evidence that mindfulness meditation is associated with a small decrease, in which, at least for low back pain, is short-lived. A systematic review and meta-analysis of mind-body practices for patients with chronic pain under opioid therapy found moderate to large effect size improvements in pain outcomes for meditation and hypnosis. A recent systematic review of studies on mind-body practices for fibromyalgia found some low-quality evidence of favorable effects on pain in comparison to usual care. The findings showed very low-quality evidence for biofeedback, relaxation-based, and movement therapies, and no advantage for mindfulness in comparison to usual care controls for specific groups of patients. Overall, the effect sizes fall in the medium range in pain reduction at best. There are important caveats that must be underscored that involve methodological challenges and optimization. The methodological quality of the studies can be problematic and reported as such. Example, the request for full blinding or placebo control as in pharmacological trials. Although this may not be fully appropriate, For many mind-body approaches, high-quality clinical data is still needed to determine efficacy and generalizability across diverse chronic pain populations. However, one should keep in mind that there's an absence of proof of efficacy in a specific criterion. Example, pain intensity is not a proof of inefficacy more globally. Based on this evidence, different mind-body techniques can be recommended for pain management. Who are the practitioners? Different individuals can be trained in mind-body practices, and in most countries, the titles of mind-body practitioner are unprotected. Example, any person can call him or herself hypnotherapist or coach in mindfulness. This is progressive development of standards of practice. University teaching and professional associations set criteria of practice. The ethical recommendations of these healthcare professional associations are for shared expertise and to build progressively through patient-centered discussions. Patients need to be educated regarding these different levels of understanding of their condition and supported in decision-making when different practitioners are available. Finally, while mind-body practices are considered globally safe when practiced by well-trained healthcare professionals, there are some potential risks of energy and physically demanding practices, such as yoga postures. Mental health risks associated with mindfulness interventions have also been discussed in recent years, although not in the specific context of pain therapy. How can these practices be included in an integrated care approach? The decision to incorporate mind-body practices into integrated care approach to manage chronic pain should be based on a careful consideration of risks and benefits, including the needs and preferences of the patient that are related to her or his beliefs and attitudes about chronic pain and its management. Arguing against or in favor of these practices with the patients and or the family without informing them of the risks and benefits may compromise the relationship and the treatment outcomes. Therefore, it's important that the patient be part of the team that decides what's best. Moreover, it's key to empower the patient to make decisions and encouraging her or him to report on the results, positive and negative, of these practices, so that new, better decisions can be made to help achieve the patient's goals. Although mind-body practices have been around and widely used in healthcare for decades, their full integration in pain management, especially within primary care, is far from being accomplished. Increased education and training of healthcare professionals to be comfortable and well-equipped with an interprofessional network and dialogue is required. In addition, systematic changes to reduce clinic time pressure and to facilitate reimbursement policies could also help diminish barriers and facilitate the integration of well-validated mind-body practices into healthcare. Integrative primary care practices or pain clinics where mind-body practices such as hypnosis, mindfulness groups, and Qigong classes are on offer for specific EBM-supported pain management indications could also facilitate the access to and integration between practices and practitioners.